What a pleasure it is to be here. This is surely a global summit, and I appreciate the scientific committee for having me here. One could get very intimidated speaking to a group like this, but like George said, I see a lot of friends out there, and it's very easy when you have to speak to friends. I'm from St. Louis, Missouri. Many of you from outside the United States probably have no idea where Missouri is. Actually, probably many of you in the United States have no idea where Missouri is. I'm originally from New Jersey. I went to dental school at Washington University in St. Louis, and trust me, I had no idea where Missouri was. But I got married. I've been there for the past 30 years. But St. Louis is right over there. We're considered the Midwest. And it's a very small city. We like to think of ourselves as a big city. You know, we're about a little over 1 million people. We have a couple of football teams, a baseball team and a football team. But right there in the middle is the Gateway Arch, the St. Louis Arch, mistakenly called. But that is the biggest tourist attraction that there is in Missouri. But when you've been doing implants as long as I have, from the mid-1980s, and you take a look at that, and if you think that was a cat skin, you're looking down on the lower jaw, on a mandible, and you see, boy, if we could go ahead and place 5 implants between a foramen and get ourselves a great 8-piece spread, just like our good friend, and I see a lot of people out there who are good friends of Charles English, just like Charles English talked about in the 1980s, and this is a concept that still holds true today. Basically, David asked me to speak on a couple of things. The first one was the essential elegance of the abutment. It wasn't enough that he just asked me to speak on the abutment, but he had to put the word elegance in there. So that kept me up for a few weeks, because how am I going to try to get that in a type of presentation? Then he asked me a few weeks ago if I would switch and do a little something else and talk about the clinical confirmation of the tissue stability. And I said that would be great, because after all, I'm a prosthodontist. I'm in private practice full-time. We have no more dental school in St. Louis. Washington University closed in about 1990. And I said that would be great, and I would really like to try to take the relationship of the essential elegance of the abutment and tie it into the clinical confirmation of tissue stability, because this is what we're seeing on a daily basis. So, in order to understand where we are right now with the abutment form, with the abutment shape and everything, we've got to understand from where we've come. And if we take a look at the abutment criteria from years ago, basically the abutment was just thought about as a part that was analogous to the root of the tooth, onto which there was going to be a margin to which we would cement the crown, the retainer, the overdenture component, whatever sort of prosthetic component we were using at the time. And if we take a look at a synopsis of the literature from those days, basically we're talking about that the abutment was just strictly looked upon as a mechanical approach. There was no biological entity into it. And that's not unusual, because when you take a look, when you think about what we thought about the implants back then, we had the implant, which was a screw, the abutment, which was screwed into that, and the gold screw, which was screwed into that. And how many times was I at lectures or people would explain it was a screw within a screw within a screw, basically all mechanical. But then we take a look at the abutment as it's evolved through the years. And Tuati and his group published in PPAD, they were talking about a different way that we need to look at the abutment. And the first thing that they said in that article, we should provide something with maximum space and avoid a flare geometry. Well, what were they talking about with the flare geometry? Well, if you take a look right over there, all abutments at that time, and if you think about all the abutments that we've used through the years, had a little flare. So, okay, we take out the flare, and that's what it looks like. Then they said that the abutment should not be oversized and divergent, but rather narrow and concave. Now, all of a sudden, you're taking a look at the abutment, and it really doesn't look like anything like we were talking about with the mechanical type of configuration that we had years ago. In fact, they went further, and they said, allow maximum tissue and stability and avoid compression. Well, take that into consideration, because now we're allowing a thicker amount of soft tissue. We're actually increasing the biotype from within by allowing that soft tissue to go on top of the platform. Take that into consideration, and in conjunction with what was talked about yesterday, particularly Dietmar Wang had a great presentation about that, about the subcrestal, and now we have nothing like what we were talking about with the original type of abutment. In fact, we have something that we're talking about with this type of abutment, where the bone and the soft tissue are growing up on top of the platform. Another article that was very interesting that was published in the Journal of Prosthetic Dentistry by Rompin and his group, and this was published in 2007. And it was about soft tissue stability on a facial aspect of gingivally converging abutments in the aesthetic zone. And this was a pilot study. And basically what they found out was that instead of having the divergency, much like Tuati was talking about in his articles in Sadum, this would be talking about the convergency over here. The convergency to allow that thicker amount of soft tissue, and then going out and developing your emergence profile. And again, when you take a look at that and you overlay that with the abutment that we've been talking about with the ankylose, or the whole tissue configuration, it's very much the same, almost exactly the same configuration. Except in their study, they only had 12 months worth of data. With this one over here, there's over 22 years of clinical data, and that's very important. This is a connection that's going to optimize the soft tissue seal and prevent the bone remodeling, as Paul Weigel so eloquently showed yesterday, as did every other speaker. Now, I have to get this in, the essential elegance of the abutment, because I wasn't going to let that go by. So I found a great definition when we talk about elegance. And you talk about elegance, the quality of precision, cleverness of design, scientific precision, neatness, and simplicity. And simplicity is really a key word, because I have to tell you, when I was first introduced to the ankylose system about 5 years or so ago, one of the things that almost pushed me away from the system was that it was so simple. I'm of the era that the more screws and overdenture copings and everything that you can show and put on something and impress people with, that was the best way of restoring it. But like George and Dennis said earlier, there's nothing wrong with the KISS principle. Keep it simple. So the simplicity aspect is very good. As a matter of fact, when you take a look at all of the abutments, what's so simplistic about it? Every single abutment they have, the balanced anterior, the balanced posterior, the standard abutment, which George was talking a lot about, the balanced base, as well as the syncone abutment. Simplistic in the fact that every one has the same type of convergency and then going into divergency. Every one is going to allow the soft tissue and the bone to form upon there. Every one, regardless of the size, and there's just so many different ways that you can customize it. I'm just showing the straight abutments. But you can see simplicity in the fact that you can determine where the margin is going to be just by strictly choosing a component with a higher type of margin. Very simplistic and very functional type of implant system as well. Now that we know what we want and have with the implant, or with the abutment rather, let's take that same type of knowledge that we have and apply it and see why the system works so well with the type of ankylose abutments. This is an ankylose abutment. It doesn't matter what type of abutment it is, because they all have the same essential flare. We're going to avoid compression on the soft tissue and allow maximum thickness. What's happened before is when we had the divergency and we were spreading everything out, that tissue was being compressed. It was being compressed because we had to have more room in this area over here for the titanium. Well, with all things being equal, wouldn't you rather have bone and soft tissue filling that area in, as long as the strength is there, rather than titanium? But you can see, because of that, why we have the maximum tissue thickness. When you take off any sort of the sulcus formers or abutments, this is just a classic look that we see. You take a look at that from the occlusal view, and you take a look clinically what we see. We don't see any platform. The platform is really not important to us. What's important to us is this diameter over here, but there again, that's just a classic emergence profile of the abutment. This is what they're talking about with the O-ring and the long-term stability that we get. Now let's go from the literature, the basic literature that I was just talking about, and go into clinical. And when we talk about clinical, we have to talk about some of the advantages of the ankylose abutments as I see it. And I've been using the system for about 4.5 years, and I'm going to go through this very quickly. The strength, fit, preservation, and bone. These are the three concepts that we need in any implant abutment interface. Strength, fit, preservation of bone. And it's very simple to understand. When we have preciseness of fits of the component, we are going to preserve the bone. We're not going to have the micro gap, and most importantly, we're not going to have the micro movement, as Paul showed yesterday, and that's going to help preserve the bone. Very important. Simple, it's a very simple system. What we're seeing over here is tooth number 30 and 31 that have to be restored, replaced actually with 2 implants. I used a very simple type of abutment, as Dr. Tajidi was talking about yesterday, and George was just talking about, the standard straight abutment, because it gives us a lot of room, but it also gives us a maximum amount of strength. And I have to tell you that in the 4.5 years that I've been using this system, whenever we have any adjacent implants, we never splint them. They are always restored as individuals. The only time I've splinted implants in the 4.5 years that I've been using the system is for a cantilever bridge or a conventional implant fixed partial denture. And that's it. Everything else is restored as an individual tooth. Functional, yesterday Paul was talking about it, the occlusal concept. We don't have to follow the typical occlusal concepts for an implant-protected occlusion. This is functional. These are on 2 implant crowns. Notice that there's not any constriction buccal lingually, nor do we shallow out any of the occlusal planes. It's just occlusal anatomy like a regular tooth. And what do we see as far as determining the clinical stability? Take a look at this from year 1 and follow it all the way through from year 2, year 3, and year 4. And also take into consideration the large cantilever over here, the small implants and the small diameter implants against a natural opposing dentition. And you can see at 4 years, we're still seeing the bone on this area right over here because the implants are placed subcrestally. And this is just a normal occurrence of what we see on a daily basis when we go back through our patient's charts. Cantilevers, we can have a cantilever with a pontic, or we have a cantilever within a tooth. Paul Weigel talked about this in one of his articles about occlusal concepts for an implant with a greater mechanical stability. And we're going to have tremendous off-axis forces over here, but the fact that the connection is that strong and these forces, the force vector, is that far away from the middle of the implant doesn't deter us from doing something like this. As a matter of fact, this lady was treatment planned originally to have 2 implants placed in that to replace that molar, one here and one there. And that's a great way to restore it if you're going to be restoring with an implant that doesn't have a greater, higher strength to the higher horizontal load. But this is a 3.5-year delivery, and just take a look where the bone is. The bone is right where we placed it at the beginning. Cantilevers, which we avoided for such a long time, we have no problem with that. As a matter of fact, we sometimes go more than just one cantilever. Now, you have to remember, I'm in private practice, so I'm not just doing these things in the university setting where which I would love to have, but I'm in private practice, so I don't want to see any failures. Because basically what's going to happen is that just for my own ego to do something, the patient's ultimately the one who's going to have the problem. So a lot of these things that I've done, while they may look a little bit strange to you, a little bit different, believe me, it was based upon consulting via emails or phone calls with people around the world who have done this system for a lot longer than I have. This lady has a unilateral, it's a Kennedy Class 2 situation, missing 2 teeth. As a matter of fact, one of the implants we couldn't place because of the nerve, and she was a little bit upset because we were going to cantilever the one tooth, and she said, you know, I gave up a removable partial denture that had the teeth all going all the way back to the molar, and now I'm only going to be getting 3. So we had her sign a consent form, we discussed it, and we cantilevered 2 pontics off that. And we look at it again at 3.5 years, and the tissue just looks the same. And by the way, clinical confirmation of tissue stability, if there was any sort of movement, if there was any sort of micro movement, you would just see it around these implants over here with a chronic inflammatory reaction. But the tissue looks just as good as it did on the first day. Now, granted, you have to control the occlusion and watches to make sure nothing's going to happen, but then radiographically, when we see it at 3.5 years, compared to when we started at the beginning, at day 1 of putting the implant in, virtually the bone is in the same location. And you notice these weren't placed subcrestally because as much of a paradigm shift as it was for us in restoring this type of implant, it's also an extreme paradigm shift for the surgeon. Even though I was there at the time of doing surgery, as I don't do any surgery myself, and I said to the implant surgeon, you've got to go a little bit more subcrestally. It was a very difficult concept for him to understand. But regardless, at 3.5 years, we still have the bone right where it is. The emergence profile of the crown is independent of the implant size. Again, a tremendous advantage for this type of system. Why is that? Well, there are 3 sizes of implants. There's a 3.5 millimeter, a 4.5 millimeter, and a 5.5 millimeter. To us in the restorative world, the only thing that really matters is that distance right over there between those 2 green lines, and that is 2.5 millimeters, because that's the distance that every single component of the ankylosing system is going to fit in there. Whether it's an impression coping, a transfer coping, any sort of abutment for a crown, retainer, overdenture, it is going to fit in there. And it's going to fit in there regardless of the size of the implant. So you can start out with a 3.5 millimeter and just go up there with a 5.5 millimeter, and it's going to be the same abutment that's going to go in. There's not going to be any difference whatsoever. It cuts down on the amount of inventory, and there are certainly some advantages of that. But let's talk about clinically how we see this type of advantage. Now, don't laugh, because the person who placed the implant is in the audience, and he's a good friend of mine. And maybe this is a new way of adjusting proximal contact. I certainly don't. I can't, you know, I can't be too hard on him. But regardless, this was going to be a situation in which we were going to be placing the implant, extracted the tooth, placing the implant, and putting an immediate provisionalization on. And I know that he placed his 4.5 millimeter implant, this B implant, because he wanted to get primary stability. And that's great. I certainly understand that. But if our crown contour was dependent upon the size of the implant, then basically what we're going to do is we're going to have a crown that's going to look like that. Certainly not very physiologic. In fact, I can go back in many of the cases that I've done through the years and see crowns like that. We weren't really delivering crowns to the patient, we were delivering rectangles, if you want to be honest about it. But when you take a look at that and you can compare it to where the abutment is, and then clinically where the implant is subcrestally to that, one has nothing to do with the other. As a matter because of that, we can start now having a more physiologic contour of the crown, regardless of the size of the implant. And what's the proof? What's the clinical confirmation of the tissue stability? When we take a look at a situation like this 4 years later. And basically, the tissue is just great. The tissue is everything that we want to be. And it's really a pleasure when you're seeing something like this. And don't let the radiograph mislead you. The minimal connection or disconnection of the abutment and low torque, I'm putting those two together. It's very important. It was talked a little bit about it. Basically, when we torque down the implant, we're only torquing it down to 15 Newton centimeters. It's at 15 Newton centimeters that screw is doing its job, and it's bringing the abutment into contact with the implant, transferring all the horizontal load, and that's why we're able to do certain things with this implant that we could not do with any other implant. And you know, it's interesting because I'm always asked, the fact that it doesn't have an index and it's just pure round 360 degrees of a conical type of abutment, even though after a full day lecture I'm showing people some, they say there has to be some movement. And I say there is no movement, it's just a different way, and believe me, it took me a long time to accept that. And the bottom line is this: if the connection was not that strong, why are we only tightening it to 15 Newton centimeters? 15 Newton centimeters is almost something that you could achieve with hands. Think about that. Some of the other implants that have indexes that you think are not going to be moving, yet they're still tightened anywhere up to from 25 to 35 Newton centimeters, yet we're only tightening this down to 15. So there are certain advantages to that. So let's take a look at the concept of a minimal connection or disconnection, or as what Henry was talking about yesterday, one abutment, one time, which I think is a way to go, and I certainly agree with that. The patient comes into my office after the implants were placed. I'll use a try-in kit, try the appropriate abutments in, and now we have the final abutments. Hopefully these are the final abutments. I've chosen the wrong abutment sometimes, but it's certainly a reversible thing that you can go ahead and take them off and choose a different abutment at a later date. But it's the final abutment. Now, there are not a lot of systems in which you can go ahead and place that final abutment at the time of surgery and then still take an abutment level impression. There are systems where you can place abutments at the time of implant surgery, but then you're going to have to take those abutments off and get a fixture level impression in order for the laboratory to go ahead and fabricate a customized abutment. This abutment right here, the standard abutment, the standard angled abutment, the standard straight abutment, is allowing me to go ahead and take a transfer cap at a later date and just do an impression right off this. And the other thing is, it's only tightened down to 15 Newton centimeters. Why is that so important? I've heard a lot of you in the audience speak before, and I've heard it bandied about that when you go ahead and you want to make sure that you have primary stability in which the implant is going to be loaded, one of the criteria that you use is that the implant is placed in that 35 Newton centimeters. Well, if you have an implant that's placed at 35 Newton centimeters and that you're then attaching an abutment at 35 Newton centimeters, now you're right at that junction where there possibly could be some movement to that implant. But at 15 Newton centimeters, we're miles away from that initial torque of the abutment into the bone and not disturbing it at all. Very important. So then the patient comes back and 3 months later, and this is the first time that we've removed the provisional. What do I have to do at this point? I don't have to do anything. Dennis Tarnow said one abutment, one time. That's the way to go. At this point, all I have to do is take that transfer cap, that snap cap, put it on top of the abutment, take my impression, my interocclusal record, and the opposing, obviously, and that's it. The patient goes home. And then we go ahead and deliver the fixed partial denture to that patient. It's a very simple concept to use, especially with standard abutments. And look at the thickness of that tissue about there, because as George said, it is so narrow and you have so much room for the tissue around there. Now, I'd like to finish up with the advantages with the ankylosed abutment is that it has multiple indications for restorative aspects per abutment. And I'm not going to go through all the abutments, but I want to just show you a few. The standard abutment, because we've been talking about that so much, the standard abutment is actually like the workhorse of the abutments. Don't let its simplicity fool you. We have maximum amount of retention here, where we have 4 grooves. You can do an occlusal retained screw crown if you want. You can do a lateral screw crown if you want, with a lateral retained screw right over here. That's got 3.5 grooves. The same concept with that platform switching concept that you can have here is going to be the same emergence profile regardless of the size of the implants. You can use these in the aesthetic zone. You can use these in the posterior zone. It doesn't really matter. In fact, like Maurice was saying yesterday, how many times do we see a patient where we did an immediate provisionalization, and a few years later the tissue contour, the tissue color just doesn't look quite the same? Well, here's a situation where we have an implant next to natural teeth. And in black and white, you can certainly see that the contour is the same. The contour is certainly great. But when you take a look at a situation, I even thought that this implant was placed a little bit much to the buccal. In fact, I gave the implant surgeon, my friend, a hard time about that because I thought it was placed to the buccal. But when you take a look at that in relation to the color, and this is the implant crown right over here, why is it we still have that great tissue color? We have it because of the narrowness that we're starting off with down here. We're having no divergency. Imagine if there was titanium coming out over here, it's going to definitely influence the facial of that. But there is nothing like that, so we have plenty of room. And you can see, even in a situation where this was placed pretty far subcrested, a little bit more than what we wanted to go, we still have a nice result. Getting back to the abutments, they can be used in any area of the mouth, not just for single restorations, but as retainers as well. And then we go to the balance abutment. The reason I'm showing the balance abutment is because I know there are some people in here who own laboratories, and this is the type of abutment that you may be using in the posterior region, the balanced posterior abutment. There again, the same type of emergence flare. You can use a lateral screw retain. You can just customize it whichever way you want. And this is a terrific abutment to use in the posterior region because of the wide shoulder that you can get around there. You can also use a standard back there. We just chose to do a fixture level impression and let the laboratory go ahead and fabricate those abutments. But take a look at that tissue. Again, this is the classic look of the tissue that we see whenever we remove the sulcus former. You can just see that classic flare. And at this point, it's a very simple matter to place the abutments in there, virtually impossible to impinge any tissue on there, ultimately get 2 crowns. And the great thing about this is that this case was done with an extraction, sinus lift, and placement of 2 implants at the same time. And when we take a look at the result, and we take a look at the result clinically 1 year, this is, again, clinical confirmation of tissue stability. It's something nice that we see in our practice on a very routine basis since we've been using this. Now let's go to the front part of the mouth, the anterior restoration. And the anterior restoration is a little bit different. You know, when we have an ideal preparation of an anterior tooth, and we know that we can't go from the buccal to the lingual in a straight line because we have to follow that parabolic curvature of the soft tissue and a bone, it's really nice to see that when we have the balanced anterior abutments, it follows that same curvature. I've had the pleasure of hearing Nigel Sainer speak about 6 times, and Nigel always calls this a sexy abutment. Now, he may be looking at something a little bit differently than I am, but regardless, it is a nice-looking abutment. It's a very nice-looking abutment. It's almost kind of like a CAD-CAM type of abutment. And we love using this in the anterior region, and now that they have the approval for the zirconia type of abutment, as also in conjunction with the titanium. But the nice thing about this system now with the balanced anterior line is that you see from the provisional restoration to the titanium to the zirconia, that same sort of emergence profile, that same sort of flare, that if you want to start off with your provisional restorations and using that type of abutment, go ahead. Then it's just a very simple matter of taking that off and switching that out for the titanium or for the zirconium, if that's the way that you would like to go. There are options, there are no limitations. In fact, when you take a look at the sulcus former, and you take a look at the sulcus former in conjunction with the balanced anterior abutments, you can see that the flare of those abutments is equal to that of the flare of the sulcus formers. So it's really a simple procedure for you to go ahead, if that's how you would like to develop your emergence profile. Sometimes, obviously, with immediate provisionalization, you're going to be doing with the immediate provisional crowns. But if that's how you would like to go ahead and do it, it's great. It's certainly a very simple way of doing it. And the nice thing about this is that stage 2 surgery, it is truly a minimally invasive type of stage 2 surgery. We're just opening that to get the 2.5 millimeter screw upon which you're going to be placing that sulcus former. You take a look at the tissue. That's the size of the implant. That doesn't matter to us. This is the size of the connection. That does matter to us because that's the only thing that we're going to be working with. And then we have the implant over here, and that's why we're able to do things like that. But the true advantage of it is really seen when you take a look at the ankylosing implant right next to a conventional implant. Ironically, both of them happen to be 4.5 millimeters. And when you take a look at them, and they're both in the same line buccolingually, you take a look at the conventional implant over here. At stage 2, that implant surgeon had to remove the entire soft tissue around there and the entire bone to expose the entire platform. Why is that? Because it's a flat-to-flat connection, so one component has got to fit flushly on the other. Now let's take that same 4.5 millimeter opening, and we'll just transfer it to the ankylose over here. Look how much more soft tissue is saved by not removing all that soft tissue. Let's take a look at it from another aspect. That's how much soft tissue we have from the buccal of the implant to the vestibule. This way we have that much. It's almost 50% more tissue by not removing it. Certainly a clear advantage in the anterior area, and that is one of the reasons why they say in their advertisements you can get a more natural color of tissue. And that's because we're preserving that tissue. We're keeping a thicker amount of tissue from the buccal, and instead of having titanium fill in that area, it's just filled in with tissue and bone. Now, our concern is not with the single tooth implants. As Dennis was saying, that's almost kind of a, I don't like to use the term slam dunk because, you know, just as soon as I do that, I'll go back tomorrow or to my office Monday and have a big problem. But our concern with the anterior area is with adjacent implants. And really to appreciate the work that Renzo did on this case, Renzo and Irene Castellini, on these two implants over here, starting off with virtually nothing to work with, is really something to see. And the thing is, when we did this, and this is at a 2.5-year post-op, as a matter of fact, Renzo published this in Ceramic Spectrum and just a couple of months ago. The interesting thing was, being in private practice, I sometimes have some free time, so I just wanted to see what happened to the bone level. And from the time the implant was placed up until 2.5 years later, I wanted to see where that bone was between an arbitrary point, between the bone crest of the mesial number 7 to that inter-implant bone. So I just started drawing some straight lines. At the time of abutment connection, that's at 1 year, and actually this is at 2 years over here. And like everybody was saying, it's nice when you see it radiographically, but really what's going on buccolingually? Well, buccolingually, we can certainly see that we have that bone right on top of that. I happen to have an ICAT in my office. I don't do any surgery, although I do extract about 4 teeth a year. Actually, 2008 was a banner year for us. We did extract 7 teeth, and I'm going to be extracting my 3rd one just in a couple of weeks. But seriously, not doing any surgery, I'm just feeling that this is the best that I can give the implant surgeon with whomever I'm working, the best information possible for going ahead. But it's nice when you're seeing, even at a 2-year, that clearly, where people say you cannot place anything subcrestally, well, you can, provided that you have the right connection. And that's what we're talking about. Now let's go a little bit beyond just 2 implants. Our patient over here has to have teeth number 6 through 10 extracted. And based upon the predictable achievable papilla height that Maurice and Henry and David have written about for many years, that was originally published in 2001, rather than placing adjacent implants, our first thought was to go ahead and place implant-ponic, implant-ponic implant. The reason for that being is that, as they say in their article, between 2 implants, you can count on 3.5 millimeters of soft tissue covering that bone, but when you have a cantilevered pontic, it goes up to 5.5 millimeters. So you're actually gaining 2 millimeters by not placing a second implant. So if I showed you this and I asked you to tell me which one is a pontic, it would really be impossible to tell because, number one, of the superior soft tissue and the superior laboratory work. But I'm kind of fooling around with you because, truthfully, there are no pontics in this situation. As a matter of fact, we went ahead and we changed our treatment plan at the last minute to go ahead and put 5 implants in. Why did we do this? Number one, our patient asked if we can do that. She was 78 years old. We told her that we had never done anything like this before, but we would try it. Again, telling her that there were some possible complications that were going to go on with this. But the other thing is this. We felt that, and we violated every rule, and this is just a case study, but nonetheless it's a 4-year post-op that I'll be showing you. Our reasoning was this. If there was no micro movement, if there was no micro gap, if there was no horizontal biologic with resorption pattern that was taking place based upon that, why can't we go ahead and do this? We were taking a chance on that, but the patient was willing to go ahead and take the chance with us. You know, and it's funny, because I always tell people, I said, don't be misled by that. Nobody is that good that they're able to screw the implant thread within the threads of the other two implants. Because what we're actually doing is we're seeing this on a curve. This is actually on a curve that we're seeing on a flat piece of film. But I have to tell you, when I take a look at the axial view of the abutments from this level over here, that implant tooth number 7 is awfully close to tooth number 8. I mean, maybe it is. I can't believe it, but it certainly looks like that. But the reason that the case succeeded so well is not what was taking place up here, but what's taking place down here. And that's the inter-abutment distance, the inter-restorative space that we were creating by doing that. Take that into consideration along with the five factors that they talk about with the tissue care connection: the subcrestal placement, no micro gap, no micro movement, the platform switching concept, and a micro roughness up to the top of the implant. And then we have something that we can bet on as far as a situation like this. And we take a look at this again from the clinical, from the occlusal view. There are a couple of things that I want you to notice. Number one, these are all standard abutments. This was an immediate provisionalization case, so these abutments never came off from the time that we went ahead and placed the implants in. The other thing that Henry was alluding to yesterday is the thickness of the tissue facial to the implant. And this is really important because these were restored with ceramo metal restorations, and we kept the titanium restoration, the titanium abutments on there. But as Henry was saying, Ronald Young had a great article that was published in the International Journal of Perio and Restorative in 2007. As a matter of fact, David had a great interview with him on Dental XP that I saw just a few months ago. And the bottom line of his article was that the eye cannot discern anything behind a tissue that is greater than 2 millimeters. So can you go ahead and place zirconia abutments if you wanted? Sure you could, but you're really not going to get any advantage in doing that. And when you take a look at that, the eye is just not able to discern anything around that. You take a look at that from the facial, look how thick that tissue is up here, and yet you're seeing that titanium go through the tissue and then just fade out. You can put anything behind there and you're not going to be able to tell what's behind there. That's one thing, and this is a proof of the crowns right over here. Now, granted, there are times that we need to have zirconia. This was, again, another case where we did an immediate provisionalization on a girl who had a very thin type of biotype. But we weren't even considering that at the beginning. It was just one of the things that we overlooked. But an extremely thin type of biotype, and we're looking at this at probably around 3.5 months post-implant placement, removing a provisional for the first time. And I said, how's everything going? I said, I'm really happy how the tissue's healing. And she said, yeah, but if you could just do something about that grayness. So I wasn't even focusing on that when we first put that implant in. But the problem is that, and the solution is just simply taking that abutment off. That's why I'm saying sometimes we do choose a wrong abutment. But because that implant conical connection is 5.7 degrees, it's very simply removed by just unscrewing it and just using some hemostats and removing it. Placing a zirconia abutment in this case, because this girl did have a really thin biotype. In fact, over here you can still see a little bit of the implant through the bone, but nonetheless you're taking a look at tissue. This tissue is so thin that I guarantee if this was a natural tooth and you prepared it for a crown or a veneer or anything, and if you used 000 retraction cord, you would still get some recession. But now coming back to our patient, this is now at 4 years. Now we did lose a little bit of soft tissue around the facial of number 7. Not because of the implant, but the patient took a turn for the worse. She got sick, she was in the hospital, had lung cancer, ultimately had something with diabetes and had to have a leg amputated. It's really sad. But we were able to get this picture. I think she's still alive. We just haven't seen her in a while. But this is where we lost some tissue. But now we're still looking at a 4-year post-op of 5 adjacent implants. And there's certainly nothing wrong with that. And when you take a look at the CT scan from 6 all the way through 10, when I did this as best as I could, you can still see bone growing over the shoulder in a sagittal direction, even after 4 years, which is really important. And so it goes on. This is what we see. We see the bone over here, the subcrestal placement of implants. Notice that these were restored as a single teeth implants over here. These were restored as splinted implants. Nonetheless, you take a look at the CT scan. That's one way of evaluating tissue stability. Clinically, at a 3.5-year post-op, that's another way of evaluating tissue stability. We're just mimicking what a root would be like that. Here's the implant here, here's the implant here. That's a natural tooth over there. And this is just what we see on a regular basis. This was interesting because after we extracted this tooth at 1 year, we're now looking at a 4-year post-op of that implant over here. But when you take a look at the CT scan again, this implant was placed 5 years ago. This was placed 4 years ago. This was placed 5 years ago. When you take a look at the sagittal view of this, we thought we were doing the best thing by obliterating the socket and putting the widest implant that we can get in there. But at 5 years, you can just barely follow that bone up a little ways on the facial aspect. You're taking a look at this one at 4 years, even under function against natural teeth, with a narrow diameter implant and a short implant, that bone is still right on top of the platform. It's just what we see, and it's just what we see all the time. And I have to sum it up by saying this: its simplicity hides its sophistications. And I'd like to end with one quote. Change is not easy, it is necessary. A paradigm shift is needed within a dental curriculum in a dental office. After all, we're in the business of delivering the best care possible for our patients. This was by Edmund Bedrosian. That was published in the International Journal of Peri in 2003. I'd like to say one other thing. Again, as I said, I'm honored to be speaking here, and I'd just like to say a special thank you to my surgical colleague, Dr. Bill Cohen, who we've been practicing in the same medical office building for approximately the last 20 years, and Bill did many of the surgical cases. And I am hard on him, that's no joke about that, but he's a good friend of mine too. And I want to thank you very much for having me here, David.